Without wasting any time, first presentation is by Dr. Irfan Jiva, and he's going to talk about management of astigmatism. Dr. Irfan, thank you.
Right, thank you very much. Organizers, chair, moderators, thank you for inviting me to give a talk. My talk is on how to manage astigmatism when we are doing cataract surgery. So this talk will be divided into what the world literature is saying and a study that we've just submitted. So in this day and age, freedom from glasses is something. Let's go. Okay. Pointer again. So freedom from glasses is something that patients are increasingly demanding. Now, majority of the visual problems are because of what we call a lower order aberration, which is spherical and SIL. But there is another aspect called higher order aberration, which we need to be aware of, but that's a different conversation altogether. We are excellent at correcting the spherical lower order aberration, but it's the cylindrical lower order aberration where sometimes I believe we need to give it more attention now. So what's the scale of the problem? A lot of studies have shown that 50% or more of general population will have astigmatism of 0.7 or above. So what are the options? The best option usually are the glasses, and people do excellent, no issues at all. If they don't want glasses, you've got the options of contact lenses or LASIK. When we're doing cataract surgery, that's an opportunity to get rid of the toricity on a long-term basis. What are the advantages? It addresses astigmatism during the cataract surgery. It has its own challenges. I believe the two very important challenges are it has a huge steep learning curve and it's expensive. Now, astigmatism. When we talk about astigmatism, it's important to know how much astigmatism is there, where is the astigmatism, and whether it's regular or not. Because remember, toric IOLs only corrects regular astigmatism and not irregular astigmatism. And the total corneal astigmatism is the anterior as well as the posterior astigmatism, and we need to just be there are two markers when we talk about toric IOLs. There's a manual marker and there are digital markers. There are multiple digital markers in the market. They're all good. Our experience have predominantly been with Verion, which is made by Alcon. And there have been many studies internationally that talk about the difference between the outcomes of marking with pen versus digital markers, and although both are very good, digital marker has an edge over manual markings. The Verion itself has got two functions. It can capture the K readings, but predominantly is a digital marker which is of importance, and in specifically digital marking, it will give you where to incise when you're making rexes, how big or small should be the rexes, and how do you position the toric IOL. And these things become very important when you're dealing with premium patients. For all of us who deal with premium patients, they demand premium outcome. And if they are paying premium price, they will not accept a result anything but the best. Now, obviously, we have to counsel them that this is not possible all the time, but the aims are such, really, and that's real life. Incision is very important. There are various softwares you can use, and I had done my own calculation of how much astigmatism I change when I incise at a certain area. So we were used to 2.75 knives, and I knew exactly how much I was changing when I came to Pakistan, and eventually 2.2 became popular. I'd asked one of the people from Alcon, they gave me a software, it was an Excel sheet really, where you put your data in. You can all do that, it's pretty straightforward. It gives you exactly what your surgical induced astigmatism would be, worth doing that. So the next few slides are some pictures of the real life Varion or digital marker surgery. Over here you can see the digital marker is telling me exactly where to incise. It's telling me to incise at 81 degrees. Because for my surgeries in my hand, every time I incise, I can induce or reduce astigmatism worth 0.22 diopters. And that is important for me whilst calculating the IOL power. And because I've already calculated that power, I want to make sure that I'm at 81 degrees and not 79 degrees. So here I'm incising, spot on where I need to be. It then tells me this is exactly how big your rexis should be, and as you can see that my rexis is exactly what they've asked me to make, which was about 5.1 millimeter diameter. Now I'm inserting my IOL, and it is advising, it's guiding me as to where my markers should be, and my lens is spot on there. Another example of where the incision should be, that's where I'm incising. My rexis is exactly where it wants to be. I'm adjusting the IOL. As you can see, the IOL had to be at 18 degrees, and it is spot on at 18 degrees. Similarly, over here, the lens should be at 6 degrees, but it is at 10 degrees right now. Now, approximately 5 degrees off can reduce the outcome to approximately 17.5%. So if a patient has 2 diopters, then they'll be left with 17.5% of that astigmatism, and that's not what we want for our patients. So looking at the digital marking, I then align it to exactly 6 degrees, and my IOL is at 6 degrees. So incision at 81 degrees, IOL at 6 degrees. Hopefully, I should get good outcome. Again, just a few more examples to show. It's quite intuitive. So if the patient starts to move their eyes, this will stop. It will tell you to center the eye. As you can see in the top left, lower left area, say center the eye. It says center the eye because the patient is moving, and it happens to all of us under topical. Now, one pointer about using digital marker, that if you use subtenon as your block, so topical is ideal of course, but if you use subtenon as block, sometimes we get ballooning, and that ballooning can cause digital marker to not identify its marks, and that can become a problem. So it's very user-friendly, it tells you exactly what to do, when to do, where to do. And most importantly, it helps me to put my lens exactly where I want my lens to be. So now I'm going to talk about briefly, increasingly when you go to EACSRS or any of these conferences, increasingly they're talking about anything which is above 0.5 of astigmatism is a complication. Now, if you have that as your barometer, I have that as my barometer. That is my standard. If my patient has more than, of course, after counseling, has more than 0.5 diopters, then that's a complication because they're not getting that sparkle vision that we want our patients to have. So we did a study on the clinical outcomes of the implantation of toric IOL. With the background that astigmatism is a problem. Lots of people have astigmatism, and it can affect the quality of vision, and we need to have accurate predictability. And the hypothesis was toric IOL implantation can reduce corneal astigmatism during digital marker associated cataract surgery, which is what we've been talking about. And the primary outcome was to assess the refractive outcome of toric IOL, and the secondary outcome was to see how much rotation it required, and if it didn't require, what was the refractive influence of that. So it was done at the Aga Khan University during 1 year period from June 2018 to May 2019, we used Verion digital marker and FRCOphth toric IOL. The mean and the standard deviations were calculated. Comparison was made by t-test. We had a statistician who did all of that, and a p-value of less than 0.05 was considered statistically significant. So we had 240 eyes, and after exclusion criteria, we had 177 patients. All surgeries were performed using this. So these are the results, and again, without boring you into it, of 177 patients with 240 eyes, majority being female. What I want to draw your attention towards is, as you can see, a lot of people had these comorbidities. Now, if a patient asks me for a multifocal lens and they're diabetic, that's usually a no-no for me. However, if a patient has any of those issues and they have cataract, which say have reduced the vision to 20/100, just for discussion's sake, and we know that the best corrected outcome for this patient would be 20/40, just hypothetically, of which the patient has about 1 diopters of astigmatism, then post-operatively, his uncorrected vision, hypothetically, is going to be about 260. He'll require glasses, and he'll be 240. He cannot be 20/20, because that's not going to happen. What we're doing here is uncorrected, we're giving him the best outcome that that person at that point in time can have. Again, lots of stats over here. I won't bore you with that, but just to sort of draw your attention that majority of the K readings were, K1 were around 43, K2 around 44, with axial length of around 23, and the spherical IOL power we used was generally around 20 diopters. In short, excellent outcomes, which matched all our statistically significant values. So the outcome of this study is that the toric IOL is dependent on correct selection of toric IOL, and that's very important. How do you select the toric IOL? So toric is all about astigmatism. How do you calculate astigmatism? So in my practice, I use the subjective methodology, the autoref methodology, the biometry IOL master methodology. I use topolyzer, and I use topography. And based on that, we then make calculations. This is something quite important, is that the, yes, we also do cyclo for these patients. Now, cyclo is important for sphere, but not for astigmatism. So if your astigmatism changes after cyclodilating the patient, don't take that into consideration. It's good if it's the same value. The outcome of implantation is dependent on the IOL, but also on the quality of data, right? So if we have a patient who has dry eyes, they will not have a good topography. They will not have a good topolyzer. If they have irregular astigmatism, they will not have a good calculation, and therefore don't even go over there, because it's not worth it. And our study showed that use of topography for cell power and axis, and use of this information on the online Alcon toric calculator. It's a very intuitive calculator, it's a very user-friendly calculator, and it has resulted in satisfactory outcomes of a patient. Thank you very much.
Thank you, Irfan, for finishing about in time. Time period allowed is 10 minutes. So जब 9.5 minutes